present as a small erythematous spots over the dorsal aspect of feet are now gradually increased up to the knee joint. The on examination, child was conscious, alert, afebrile, pulse was 86 per minute. She is normotensive. The edema was present over the leg up to the knee, which is pitting in nature. But and the macular rash, which is the multiple erythematous rash, which is present, it is non-blanchable and present over the dorsum of feet and coalescing to form the patches and extend up to the knee joint. On the systemic examination at that time, there was fine repetitions were heard. On further investigating, the hemoglobin was 10.3 and TLC and count was 12,600 with 3.75 lakhs respectively. The inflammatory markers were suggestive of CRP of 56 and ESR of 20. On urine examination, there were 75 RBC per high power field. With the above complaints and findings, she was further subjected for the chest X-ray, which was suggestive of homogeneous opacity over the bilateral mid and lower lung fields, and HRCT shows few nodules with the ground glass opacities over the right upper lobe and bilateral lower lobe, suggestive of alveolar hemorrhage, most probably the pulmonary vasculitis. Hence, further we investigated on the terms of vasculitis, and the ANCA which was sent turned to be the positive, and from further C and P ANCA, the C ANCA with PR3 antibodies we are found positive, which was present in the 75% cases of the granulomatosis with polyangiitis. It can be positive in other small vessel vasculitis, but like MPA and eosinophilic granulomatous polyangiitis, but the positivity rate is very less. According to 2012 Chapel Hill's consensus conference, we diagnosed her as a ANCA associated small vessel vasculitis, C ANCA with PR3 positive, most probably granulomatous polyangiitis, and using VCRC scheme, she had a limited disease. So we started treatment as an active non-severe granulomatous polyangiitis using the ACR 2021 ACR guidelines for the management of ANCA associated vasculitis. For the induction phase, we started the tablet Deplopart with the dose of 1 milligram per kg, and for the 4 weeks, and slowly tapered by 15% every 3 weekly. And for maintenance phase, tablet mycophenolate mofetil were started with the dose of 1200 milligram per meter square per day, and plan to give for 12 to 18 months. For cotrimazole prophylaxis were started for the against the infection of pneumocystic Jirovecii, and now she is kept in regular follow-up with us with a Birmingham vasculitis activity score, which was 15 at the admission and 4 was at the discharge. And the take-home message is the vasculitis syndrome are relatively less frequent, but not extremely rare. So so high level of suspicion is needed, and children sometimes present with the partial criteria that involves over the time. Hence, close monitoring and regular follow-up is required in this patient. Thank you.
काय हो करतो 5 मिनिटात माझी दाढी आठवतो.
Thank you, sir.
Solve the queries from you.
Yeah. It was
How the diagnosis of SLE was met? Because the history diagnosis met criteria. In your case, I don't think they were following those SLE criteria. That is one. As there was 18 only. What was the reason for that? Sorry. These things are all pulmonary renal syndromes. Pulmonary syndromes. Where there is a pulmonary capillaritis. Pulmonary capillaritis. What are the other differential diagnoses if you do not go for this? Case like this, when you get a rash and hemoptysis. It is basically a pulmonary capillaritis, massive bleeding in the pulmonary area.
so it
Do
could
you
be
consider any drug which can give rise to such type of picture?
yes, sir. Propylthiouracil, minocycline drug, hydralazine. These are the drug which can
cause skin rash.
pulmonary capillaritis, but
No,
not
that is
associated
there.
with it.
What about rash? What are the other diseases where you get a rash in pulmonary?
So
manifestation?
SLE, MPA, good pasture syndrome. These are
So in short, this is nothing but a pulmonary renal syndromes, where and what was the creatinine albumin ratio?
1 point.
so initially at first visit it
What
was
is
1
the-
point
What is the range of nephritis or a nephrotic syndrome?
nephritic.
Nephritis. So again, it fits. That is a pulmonary renal syndrome disease. Like there are, what are the other diseases like you can think of before going to the investigation? I rightly what Satish has said. An excellent purpura, classical that rash. If you have seen that rash first,
Yes.
neck and purpura. Nowadays they say IgA vasculitis.
Yes.
Today they say that when you go for the skin biopsy, they find IgA deposition in the capillaries. So similarly, but I look at the and what about the other manifestation of vaginal granulomatosis? We do.
So we have done Waters view X-ray, but there was no findings on that. It was within normal.
What
Clinically,
is the common clinical presentation of the vaginal disease?
sinusitis along with upper and lower respiratory involvement is
Nothing was
present.
there.
No, sir. If for first it was not.
Involvement is there.
At the second time it was there, but initially it was not there. Lower respiratory was there at
I
the second.
wonder how do you make a diagnosis of SLE and right from first this? I don't know. So, what was the reason for the low hemoglobin?
Yes.
So anemia of chronic disease.
Anemia, chronic disease
Seven.
with such a high ESR, sorry, CRP. So,
Because of
rash with hemoptysis and hemocitosis.
hemoptysis, you don't have a skin manifestation. So there are diseases like Paget syndrome, where it is skin vaginal disease, where it is hemoptysis and this. SLE, yes. Sometimes rheumatoid arthritis, you can have pulmonary involvement and the skin manifestation. So these are the other differential diagnostic types. In short, it is nothing but a pulmonary renal syndrome disease. And then you separate out with the investigation as I did in your case. Okay.
Thank you, sir.
That was indeed a wonderful case with the simple symptom of leading to the vaginous issues. And with such a wonderful case, I request our chairpersons to felicitate the speakers, Dr. Nisha and Dr. Vasant. Please come forward. Sir, Dr. Raut sir, Dr. Khobrakare sir. Thank you, sir. Thank you all. So as Khobrakare sir said, today we are having clinical symptomatology, the basics of our pediatrics, basics of our medicine. And for our next speaker, he doesn't need any introduction in Nagpur or outside Nagpur or at international level. Sir is a par excellent teacher, academician, our guide, our mentor. I remember, sir, I have attended your UG clinics in Sri Clinic every Sunday. And we know he has developed ABG app that is working wonderfully. And his interest in technology, and he has developed a wonderful machine, NIV, non-invasive ventilation. Yesterday, I think there was some lecture at Texas also. So here is our own Dr. Dev Pujari sir, the par excellent teacher, academician, and sir is going to present on clubbing and from here where I go. Over to you, sir. Thank you.
Good morning, and Archana, I'm humbled with your introduction. Thank you. So, today's presentation is on one of the unusual disorders presenting with clubbing. I would like to take you a journey through the genetics, how it's going to change medicine in our management, personalized management, and diagnosis, how things have changed. So I saw this child about 2.5 months back before I went to US, and you have audio here? Audio is on? Okay. So this is about 4.5 years old child. You can see the video. And he presented with thickening of skin of palms and soles, painful joint movements, difficulty in getting up from sitting position, and has had. Doesn't matter. No. वो नहीं दिख रहा है? वो नहीं आप मुझे Zoom पे नहीं दिख रहा है. Zoom कहाँ में? And put it on Zoom. See. Okay, so you got into Zoom, but should be okay. Now he has been suffering for last about few years. The rash was involved when basically palms and soles. There was some keratosis. He had hyperhidrosis. So this was the presentation, and he has had clubbing. Both the toes and fingers, the skin was affected. There was a bit of difference between the clubbing that you would see in typical cyanotic heart diseases than what you would see in this condition. So the skin over these areas was not normal. So this is how the toes and fingers look like. It was very difficult for him to write hyperhidrosis for an important feature. He has been good in studies and developmentally he has done well. There's a very interesting family history. I mean, of course, I'm not going to go through the usual investigations that one would do. So we had done all kinds of things, hepatocellular, renal functions, inflammatory markers, they were all negative. His ESR was normal. So as such, nothing on the routine investigation. It was essentially a clinical diagnosis. You can see the X-ray of long bones and they were normal.
Just a second.
Yeah.
It is not visible on that.
Okay. So,
Share from back.
back curve. Keynote. यहाँ से that's the trouble with I can use my Mac for that. Zoom का ये problem है. Keynote.
Share back.
Mac है मेरे पास. कर सकते. टाइम जाएगा इनका. क्या करें? You mind if I change on to Mac with the problem with Zoom? C to PG.
SD map.
Right. हॉटस्पॉट कोणाचं नाही. आता जाते. Hmm?
1, 2, 3, 4, 5, 6.
Right? Zoom app open करू की याच्यावर जाऊ? कशावर जाऊ? चल का? Right? I've been ready, but there is a problem with Zoom. Great. Yeah. Okay. You want me to go through? So the idea of presentation was, since the time we were posted students in IGMC, Raut sir विचारायचे क्लबिंगचे causes सांगा. तर 15 मला आत्ताही पाठ आहेत. Okay. प्रश्न आहे की why is this happening has always been my thought process. Okay. So we studied through this, and now, yeah. Yeah. Oh, seeing my grandson there. Keynote today. Keynote present होते हैं. Share. Stop. नहीं का? Sanitary statements of behavior connection. No? And Apple is a problem. The safety fellows, they will not allow any interactions. Name is a problem. Okay. Keynote करना. Screen घेत नाही तो screen share का सांग ना मला. मला right साठी screen share दे. दिले. And then why is this not happening? हाँ? एक मिनट screen share करता हूँ. So that it is so. Huh? Are you there? Okay. Was visible? So let's do it. Yeah. It's coming?
इकडे नाही येते
इकडे येत नाही ना. ही कशी येते इथून येते. ओके तुम्ही झूम करतो सरळ प्रेझेंट करतो तिकडनं दाखव. ठीक आहे स्टॉप शेअर.
अभाव पढ़ाई वाले
तिकडनं तू कर. ठीक आहे.
साऊंडला काय झालं?
आइए बाबूजी, मेरे को प्रियंका को फाइल दीजिए। लाइक की मामा फाइल दीजिए, मैं बुलवा लेता हूँ। दे बाबू, आइए, मैं 2 मिनट बुलाता हूँ। हाँ बाबूजी आइए। बेटा वैक्सीन निकाल दे। बाबूजी बैठिए, वैक्सीन निकाल के मैं फेंक दीजिए। पहला नंबर, हाँ आप दे दीजिए। मैं रियान का है पहला नंबर। हाँ हाँ है ना, मैं बुला रहा हूँ, मेरे पास ये लिस्ट है। त्रिधा का 11 बजे 10 मिनट का। आपका सेकंड नंबर है। हाँ मैं बुलाता हूँ, मैं बुला। भाऊजी एक मिनट, इनको चेक दे देता, मेरे को बिल दे दे बेटा।
Yes, sir. Yes, I don't have a list of conditions available. Well, they would come up tomorrow, but presently I don't. That's not. But
The problem, but then. And I was really mind blowing and.
yeah, we- Right.
medical diagnosis. So my case is not a complicated case; it's a simple case. The only thing about sharing this on this platform was ki, I think we might everybody neonatologist pediatrician can do come across this kind of simple cases in our clinical practice. And whenever you see a similar kind of case in the near future, it might help you in certain point of view. So this was a child which we saw 1.5 months back, and around a month-old child. month-old child who presented with almost 3 weeks of fever, intermittent fever. So they were the resident of Madhya Pradesh, so no documented history of fever. But the mother used to say the child used to have always used to feel the child was having warm, and at times she was giving medicines almost once or twice a day, and it was persistent since last 20 days. So along with fever, no other complaints. The child was active, the child remained active, the child was feeding well. On detailed history, we saw tried to evaluate, the mother was having proper milk secretions also. So surprisingly, prolonged fever in a small child who is doing very well, otherwise who is feeding well and active. So we always have to think, first thing comes to the back of the mind, are we dealing with some non-infective causes of fever? But obviously trying to rule out infective causes are a priority. So not gaining weight, the child's birth weight was 3.2 kg something, and this time at around 1.5 months of age, the child's birth weight was 3.5 kg. So only 300 grams of weight gain in the past 1.5 months with fever. And I think today is a day of rashes and skin. So dermatology is such a vast subject and the largest organ. कितना भी पढ़ेंगे तो कम जाएगा ऐसे. So still learning certain things in that. So birth history not significant, short stay of NICU stay not significant otherwise. So we have a case of 1.5 month old child not gaining weight, intermittent fever, otherwise no systemic symptoms like poor feeding, lethargy, ear discharge, or difficulty in nutrition, or any bladder So the mother was saying that I was having some skin lesions since last 2 weeks also, and which were persistently increasing. So we thought that might be the catch of our diagnosis about this child suffering from. He was evaluated before coming to us. Septic profiles at least twice before coming to us had been normal. So directly come to the point. So this was a clinical photograph. If you can see in both the photographs, the first photograph you can see multiple lesions all over the back, and the soft, non-tender, slightly erythematous. I think you can see more faint erythematous rashes might not be very evident in the clinical in this photo, but multiple lesions all over the body. And they were non-tender. It were predominantly present over the back, abdomen, and some neck, not much over the limbs. So fever, prolonged fever, and small child with skin lesions, with multiple skin lesions. We thought first thing we came to our mind, are we dealing with some subcutaneous abscesses. So because fever was the primary presenting complaint of the child. So clinical diagnosis at this point of time, some kind of subcutaneous lesions, not sure. Primary diagnosis of abscess or infective pathology, or some non-infective causes like subcutaneous fat necrosis. So as expected, the septic parameters were normal. Urine routine was normal. USG KUB was normal. One purpose of doing USG was to rule out any infective focus in the abdomen also. Between needle tap, it was dry and no pus collection. It was mostly serous collections. So that we then consulted our dermatologist also, and then we thought we are dealing with a case of subcutaneous fat necrosis. So no significant perinatal or postnatal history. It was spontaneous. The child presented with that. So what next? So the problem with subcutaneous fat necrosis is the major concerning factor is hypercalcemia. We have been dealing with always in our clinical practice, we see lots of hypernatremia. Slightly lower, we see more of hyperkalemias in ICUs, and hypercalcemia is a bit rare pathology, rare thing to see in our clinical practice. The child's ionic calcium was 1.8, which was very high. So if we see in terms of just serum calcium, it might be around 14 to 15 milligram per deciliter, which is on the very higher side. Phosphor was surprisingly normal, so that rules out any hyperparathyroidism. Yes. So we did a vitamin D and parathormone levels to rule out any other pathology. Parathormone levels, as expected, were on the lower normal side. Vitamin D levels were normal. The high calcium was seen in the urine also. Urine calcium create ratio was very high, and there was no nephrorachinosis in the USG QB what we had done it. So we had a simple but rare diagnosis, and with subcutaneous fat necrosis with hypercalcemia, also with hypercalciuria, leading to failure to thrive. Hypercalcemia, children do have irritability and polyuria, polydipsia, constipation, hypotonia, and all these symptoms. So maybe the polyuria, which was not there in the history as such, might be leading to failure to thrive to the baby also. So the primary thing, our goal was to treat hypercalcemia in this patient. You can see the lesion on the nape of the neck also in this photograph. So we thought since it's a rare thing to treat, we thought we should have an edge in our treatment process. So we consulted, we contacted Dr. Hari Mantaria, pediatric endocrinologist. I would ask Hari to take over from here. He helped us in the management of hypercalcemia, because hypercalcemia has a lot of acute and chronic issues. Hari will take it.
So thank you, Dr. Yadav, for inviting me, and I wish you all a very good morning. And it always leads to anxiety after if your presentation is next to Selvas like Dr. Dev Sujari, because it automatically raises the bar and it actually makes. But this was a very simple thing, but very rare. And why the idea of presenting this to have this thing in back of the mind. Okay, so when I was called and this calcium was 1.8 with the failure to thrive like presentation. So what we did is the standard management of hypercalcemia. That is, we give saline diuresis, we give extra maintenance IV fluids along with loop diuretic, that is furosemide, and prednisolone was also added in that. However, some people, they mentioned adding hydrocortisone, but here we gave prednisolone. So coming to so the child was started on normal side. Now this we come across very funny situations. This patient has come from Satna, and from day one he had only one thing to say: I don't have money. That is the biggest challenge we face. Actually, we are not lacking diagnosis or expertise. What we are lacking is the commitment, and that I have observed over a period of time. That many patients, we know what has to be done and what needs to be done, but the patient is either lost to follow and we are not able to help, or come with severe sequelae. So here, if you have seen the investigation, we were not able to do a 125 dihydroxyvitamin D also. Someone might ask that if you are claiming that it is because of that hypercalcemia, could be because we are going to the pathophysiology once we discuss the literature. But we could not do that also. The patient had first, and I think the hospital did a great job by not charging them for the next 2 days. Only thing is you get better and go. And the patient has not come for follow-up. These are the follow-up on WhatsApp. These are WhatsApp follow-ups. So ionic calcium at presentation, there were symptoms, and we had furosemide at 2 mg per kg per day along with prednisolone of 2 mg per kg per day. Second day we repeated, it came down directly. So that diuresis or saline thing, IV, it worked, and we had a less irritable child with a ionic calcium 1.59, and we continued the same therapy. On day 4, because we actually, the hospital sanctioned 2 days of free stay and all. It came down to 1.47. The child was alert, happy looking child. And we reduced the dose of prednisolone only, and we sent them home on oral furosemide and prednisolone. On day 20, when we contacted sorry for this technical issues which are going on. So when we called them, it is not the patient who called. We called them and asked, how's the child? He said, child एकदम अच्छा है, कोई problem ही नहीं है, everything is fine. जब लाए थे तब भी अच्छा ही था. And this is how they have reacted. So I said, okay, you stop prednisolone, and what we'll do is we'll do only ionic calcium. So it was 1.4. So very slightly, I don't know. In between, they must have stopped something. I mean, they stopped using this furosemide and all. They always have this reason. But last week when we called them, they said, "Aana to possible nahi hai, thand bahut hai, and corona bhi hai, and all these things." So we just told them to get any calcium done. And we reduce the dose because the child is growing, so the dose automatically came down to 0.8 milligram per kg. So child is presently on 0.8 milligram of furosemide with slightly higher side of ionic calcium. Ionic calcium 1.35 would have been an ideal upper limit of normal, but 1.38 is acceptable. This is last week's report. So it's not moving. And we actually, I requested them to send the child's photograph back, at least for the sake of this presentation only. I told them, you please send a photograph, and this is what they have sent. And this is how the child looks now, though we see in the child. But coming to discussion of subcutaneous fat necrosis, a rare paniculatis, and usually presents in first few weeks or 10 days of life. But here the different thing was he presented quite late, 1.5 months of life. Now pathogenesis is unclear, but it has been postulated that a perinatal stress might or hypoxia along with some hypothermia can lead to necrosis or inflammation of the subcutaneous fat. And they usually present with a typical skin lesion of firm erythematous or indurated plaques, and which evolve to subcutaneous hard or painful nodules. So here, I don't know, the child won't be able to tell about pain, but it has been written that it has led to painful nodules. So handling was difficult for the mother. Whenever the mother was, in retrospect, because in presentation it was said that it was a painless lesion. But yes, the mother was very or the child became always cranky whenever the mother. Skin biopsy is done in only cases where there is a doubt, where we don't know and want to find out the cause of that thing. But here it was very, very classical. It was presenting with hypercalcemia, then doing a skin biopsy just to and here I think cost would have added to it. So we didn't do it. And differential diagnosis, we had scleroderma neonatorum and cellulitis. So there was all the markers of inflammation and all were ruled out. So what are this is the thing which happens most commonly in full term. Usually we get all the diagnosis in preterm babies, but this is mostly a disorder of full term, and the maternal factors associated are preeclampsia and gestational diabetes. They are the reported maternal factors. But if you see the neonatal factors, it is said that traumatic delivery or asphyxia or fetal distress can be a cause, or meconium aspiration, and recently therapeutic hypothermia, which people have started using it to improve the outcome of HIV kids. Will be able to tell more about it. So this is one of the risk factors labeled, and for some literature suggests that it was present in almost 20% of the cases when they reviewed the literature. Now what happens to this subcutaneous fat necrosis? What's happened? Usually it's a benign course, uncomplicated, without any disturbances. So it comes and goes, and the skin lesion might take around 3 months to resolve. And there could be some fibrotic scars which might develop, but not in all. The sequelae is rare. But it may have almost them may have complications. The most common complications: hypercalcemia. The complications include thrombocytopenia, hypoglycemia, and hypertriglyceridemia. Thrombocytopenia was not there in a child, and the child never had hypoglycemia. We could not check the triglyceride level. Actually, we didn't suspect also. Now, hypercalcemia, when we're talking about hypercalcemia only in subcutaneous necrosis, the incidence is 25, reported incidence is 25 to 65% in various literatures. But the most unanimous thing is it happens in term babies. So more than 90% of the cases happens in term babies. And the cause, again, the postulated cause is this granulomatous inflammatory cells. They express high levels of 1,5-hydroxylase activity, and they stimulate the intestinal calcium uptake. So it activates the 25-hydroxyvitamin D2 calcitriol and increases intestinal calcium absorption. Now there could be PGE level induced increased bone resorption and increased calcium mobilization from resolving areas. So these are the three postulated, but we don't have a proof of anything in particular. These are the pathogenesis, or these are the postulated cause. Now, what happens to this hypercalcemia of SFN is it usually presents in first month of life. Here the child was symptomatic in the first month, however presented 1.5 months, but presentation can be or is 6 months afterwards, and that's why it is very important to have a long-term monitoring of such kids. Now, hypercalcemia, so a distressed child, term child at a birth is distressed or complicated delivery, then such child should also be looked for the development of the skin lesions for as long as 6 months. Now, hypercalcemia can be mild and asymptomatic. So many of them we are missing out because they are asymptomatic, they are mild hypercalcemia. But symptoms of which happen or symptomatic hypercalcemia, the symptoms are lethargy, irritability, hypotonia, vomiting, polyuria, which was there in this child, and dehydration, constipation. Now, sometimes they might have severe, few percentage they will have severe. These complications can be acute, leading to cardiac arrest and renal failure, or there could be chronic complication like metastatic calcification like nephrocalcinosis, nephrolithiasis, or calcium deposition in the myocardium and brain. So these are the complications we are looking at. How do we treat? We have to restrict calcium and vitamin D intake. That is the first thing. Second is intravenous hydration. Loop diuretic is used to induce calciuresis and avoid calcium resorption. And glucocorticoids, they are recommended, and mechanism of action of glucocorticoids include reduced intestinal calcium absorption, increased renal calcium excretion, and degradation of vitamin D. So activated vitamin get degraded. So these are the three proposed mechanisms of giving glucocorticoids. Now, bisphosphonates can be a choice in severe variety of, so pamidronate or zoledronic acid can be given if the hypercalcemia is intractable and it is very severe. So these are the treatment options. But here the child responded to most of them. They will not require. If I've been reading this in 2-3 days, so I could see only 2 or 3 case reports requiring bisphosphonates. Otherwise, there were no bisphosphonates and never rejected. They are an option. So with this, I would like to thank you all for the patience.
I just want to know why majority of the babies, they have got this fat necrosis thing over the back of the child rather than on any other body. Majority of them, they have a distribution over the back. But
Yes,
it is easy to the pressure effect which is responsible. That is number one. Second is the role of macrophages activating lipids into 125 diaroxy, vitamin D, and to hypercalcemia, because some books have mentioned that the macrophages get deposited in those sites and they are firm nodules, painful nodules, of course, and
Yes.
they are responsible for that. And the role of feed, I want to know whether these cases reported they are more often the best feed or with the top feed or any other apart from this pain relief, because pain reliefs, most of these cases they occur after say 1 month or so rather than immediately in the neonatal period.
Yes.
Now, you said that if it is perinatal event responsible for that, why there is a lag of such period? You give rise to necrosis at the age of 1.5 to 2 months of age. That is another issue. And is this particular diagnosis on the life of the child? Does it, the serum calcium mounts up so high that the patient can sometimes by mistake or by accident have
Yeah, so,
there are certain various which
so coming to this severe variety, most of them, if they succumb, it is because of undiagnosis or people are not able to make the diagnosis. They are
many
not
reported
unaware.
cases where serum calcium mounted very high and then patient
I could not,
because of the cardiac arrest or something.
but
Not there.
I haven't actually, but there might be cases. I mean, definitely nothing in medical science that's not there, must be there, and probably it is a bias of reporting. Once you have a complication of fetal fat necrosis, if it is just a fetal fat necrosis result, they might not go for publication.
Because it is self-limiting, does it that the serum calcium mounts to certain level and then gradually of its own?
Yes, so severe variety have been.
Or whether some are missed and they die because of, and we label them that they are because of SIDS or the sudden infant death syndrome or something or the other. So
Case reporting suggests you any mortality as such. If you have no case reporting of mortality due to subcutaneous fat
Is not there.
Becoming a self-subsiding disease.
is not
And
there.
over the back, no specific cause, but maybe the amount of subcutaneous fat located in the abdomen and the cystic
But
might
it
be one of the
deposited
reasons.
all over, not just the back. You have got the cheeks full of fat, you have got the belly full of
Yeah,
fat.
perhaps a positional, it could be.
So is it the position is from the pressure effect giving rise to such type of
Yeah,
phenomena?
already compromised subcutaneous
Because
fat
I
might
have
get
seen
more
the
of.
cases, they all sat on the back only. So I just wanted to know whether such relation with the posture of the child and any prophylactic role of any mattress which should be soft enough to bear such babies so that such events can, because you said the reported incidence as 20 to 30% is a pretty high incidence.
Sir, hypercalcemia in subcutaneous fat necrosis. So incidence of hypercalcemia in fat necrosis, once we diagnose it, then it is 20.
The level reported in this.
Sir, highest level,
calcium.
1.8.
1.8.
Total calcium.
Total might be around, this would come around
80.
14 to 15.
I came across
They have classified hypercalcemia, the mild variety and crisis, hypercalcemic crisis. So if your child, a subcutaneous fat necrosis, has a calcium level more than 15, they are bound to go for a hypercalcemic crisis, and that is life-threatening. So, but if you manage them properly, they may not die. That is a different aspect.
yes.
but they can go for the life-threatening consequences, and that depends on the level of the serum calcium in the blood. They say in some book, they say more than 14 milligram is said to be a hypercalcemic crisis.
Yes.
And below that, again, there is a level when to say hypercalcemia. In some book, they say more than 11 total.
Yes.
But the new Nelson 24th edition, they say 10.5.
Yes.
So even more than 10.5 can be labeled as a hypercalcemia.
Yes, sir.
Okay. In this case, the case is seems to be very straightforward, looking at the baby's picture and the level of the calcium. But when in some cases you are not very certain about the picture, so they say what was the level of the parathyroid hormone, and you said phosphorus is low in this case.
The normal, sir. 4.6. It was 4.6. 4.6 milligram per deciliter.
Calcium is phosphorus is normal. What about parathyroid hormone?
4. So suppressed, adequately suppressed, sir. 4 picogram per ml.
So when the approach to the hypercalcemia, basically leave apart this.
Yes, sir.
When you get a calcium level more than 10.5 or 11 per 100. So there are basic investigations one has to carry out, like calcium, what you have said, phosphorus, alkaline phosphatase, and parathyroid hormone.
Yes, sir.
And if your parathyroid hormone is above more, there are two conditions: hyperparathyroidism and the familial hypocalcemic hyperparathyroidism. There are only two conditions. In rest of the condition, this parathyroid hormone, they are low. So that will differentiate between your conditions and your strategy for the further diagnosis. Another important thing is not only parathyroid, but upon the level of the phosphorus. Okay. If your level of the phosphorus, they say, if it is normal, that will talk about the vitamin D. That will talk about the vitamin D intoxication. And in when you go for the level of the vitamin D, that is 25 OH, that will indicate about the vitamin D intoxication. But the rest of the conditions where the calcium is more, this 25 OH does not give any meaning. In that event, you have to go for the 125 vitamin D, which will tell you whether you are dealing with the other causes like vaginal and all those things. So that is there. And if your phosphorus level is say low, that will again indicate whether you are dealing with a vitamin A intoxication. Because most of the time we give vitamin A and vitamin D, and they present with a non-specific manifestation. So the level of the calcium would answer. But and another important thing is clinically when you are giving a steroid does help in rest of the condition than the hyperparathyroidism. So that will differentiate the conditions. It's a very good case you have presented, and
thank you so much, sir.
And very transparent, and you have shown the response to your therapy. And again, what about this steroid? Another important thing: do not use thyroid diuretics. Do not.
Nephrocalcinosis.
Again, it will exaggerate the picture because it is one of the causes of hypercalcemia. So when you are using these diuretics, always remember: do not thyroid diuretics. That is very, very important when you. And they say in most of the cases you give normal saline 2 times maintenance plus loop diuretics. Most of your children, they respond, and in those conditions where there is no response, then you may use steroid. You may use methylprednisolone, you may use this. There is no difference. Whatever you like, you can use.
And in fact, what added to our agony is we asked for electrolytes. We asked for serum sodium because we are putting on long-term furosemide. They didn't do that also. They only did that.
One point was, this patient has clearly submitted diagnosis.
Yes, sir.
Baby brother is fine.
Yes, sir.
Right. I might have a different opinion on management. But to me, this baby has
Huh?
Subcutaneous
No, no, very good.
hypercalcemia.
Yes.
Let's imagine, why do we want to treat it? I mean, what I would do, how would calcium harm you?
So there was increased urinary calcium creatinine ratio that might.
How would it harm? By cardiac tox.
Yes.
not renal tox,
Yes, sir.
Right? Creat is normal.
Yes, sir.
I would take an ECG.
That you must.
Now, if my ECG is normal, I would closely observe this. In fact, on digital net, about few years back, I had a good discussion on serum potassium in neonates. Now, laboratory shows the potassium is very high. I kept on observing, I said, my ECG is normal. I said, my ECG is normal. Okay, if the potassium is 8, I'm observing this very closely. This baby, if the baby is not affording, as you rightly say, then I would not even do, why would I do phosphate or something? I would say 5 necrosis, hypercalcemia, stable baby, cardiac activity stable. Renal activity, yes, I'm going to hydrate it properly. That will ensure that it is properly hydrated. And I think that should be enough for.
Yes, and that is what we did actually. And that actually turned because the child was symptomatic and only 1 year saline. It flushed.
Yeah, why would you steroids?
But one thing is that
Sir, we don't. I will give this answer. Why we had steroid? Because they were like, we have to send them home. We have to discharge them home. And why I gave steroid is we don't know when the serum calcium might go higher up. We need a close observation.
And that's what's not going to happen is coupled with them,
Yes.
proper feeding and the baby's passing adequate urine. Okay, and I demonstrate increasing rate. Okay.
Yes, sir.
And say calcium create normal, ECG normal.
Yes, sir.
I would ensure that I mean these are
Yes, if baby goes then I might not add prednisone. I might not add prednisone. That's point well taken, sir. But because the technical thing we have to say.
Where was this ionic calcium?
Initially,
No, from the periphery.
they might have got it done.
I am surprised. I mean, I know this, your ionic calcium, you need electrolyte sense. Not often with APG machines, and otherwise, a lot of these fellows will not have it. What they do is get calcium done. Calculate this and she
Calculate.
I spoke to one fellow. I said, ionic calcium आपने कहाँ से किया? this serum calcium किया ना? ये कैसे बताया?
Calculated value for albumin levels.
Roughly what you can take, ionic calcium is half of.
They will affect. So basically, I would then take
Yes.
Suppose total calcium 14 and I say normal, I will not.
That is same as but as far as
but that's not great.
so what I do is total calcium whatever they divide by that is the number is now to convert into millimole per liter you have to divide by again. So they divide by total 4 multiplied by 8. So total calcium divided by 8 gives you ionic calcium.
Is that can
No,
Studies on how Another thing, hypercalcemia causes death, and I think there are two types of hypercalcemia. One will be like acute and one will be chronic. So acute has got more chances of death and all those things. Here, I think it has been happening for a period of
Cardiac and CNS both. They can land into encephalopathy also because of hypercalcemia.
Sir, as you rightly say, any electrolyte, acute and chronic. If this is not something which is suddenly caused, by and large, this should be all right, even with good hydration.
Yes, absolutely. It might get adjusted and might not manifest.
Not where you just don't just above 14, you have to go shoot on the.
And with a good hydration and these diuretics, serum calcium comes to normal within 2 to 3 days.
Yes, sir.
If your management is very correct and your diagnosis is correct. Because in most of the literature it is said the serum calcium comes to normal within 2 to 3 days.
Yes, sir.
And if it does not, then you have to search the cause for the hypercalcemia. So it is very, very important to manage when you are managing it. And it is well known for every disease. Everything will have. And ECG changes would come after 12 milligrams. And what I want to stress, ECG is best than the level of calcium. Why? Because there could be a fictitious level of calcium. So your ECG changes are there.
ECG is poor man's average.
So ECG changes are there.
Yeah.
That indicates your level of calcium is more than 12. And initial changes, that more than 12 is ECG changes.
Sir, the ECG changes will depend on ionic calcium. Total calcium will depend on a lot of factors would affect the part of ionic calcium as a segment.
What level would you take for ionic calcium for these ECG changes?
I will say about
In most of the book they have mentioned about the total total calcium. If your total calcium is, and indirectly what I say, what you rightly said, the ionic calcium is much better than total calcium. But if the ECG changes are there, your total calcium is more than 12. Because in most of the book they say total calcium. ECG changes.
ECG changes will depend almost entirely on ionic calcium. The total calcium is not electrically active calcium.
Then the total calcium also has ionic calcium.
No, but there's a proportion answer. That could be. That could be.
There are a lot of cases of hypercalcemia in most of the babies who are managing peripheries. And the reason being simple that babies that kept on the hypothermic surface and subsequently develop this kind of a lesion. The first and foremost thing this baby comes to OPD is the thing you just evaluate ECG and calcium. And very less likely this baby is going to have any kind of changes on ECG because it's a chronic hypercalcemia. Now I have a question regarding management. See, there is hypercalcemia and the baby is depleted because that is a what you call a baby is trying to decrease his calcium level by having polyuria. Now, what causes this kind of stuff is nephrocalcinosis, which is not going to there at presentation. But once you add furosemide, once you increase excretion of calcium by pouring more of fluid, this baby they are going to develop nephrocalcinosis in future. This is proven literature. So when I will add furosemide when there is a life-threatening hypercalcemia, if there are ECG changes, then only I will add it. And if you will go into pathophysiology, why this is happening, it's mostly because of chronic granulomatosis. That is granuloma which are present in subsequent tissues, which are secreting some of the substances which will tap into the RSP. So only thing to suppress the inflammation is steroid. At that time. There are differences in opinion also, but you never know on which curve you are. Either you are on increasing curve or you are on downfalling curve, because this is going to resolve spontaneously. So if hypercalcemia is gradually building up, then the thing is steroid is the treatment in this baby. And giving more of fluid depends upon your calcium excretion. If it is on at the higher capacity, then that may also be detrimental. So this is the medicinal spondylosis case, which requires only just steroid if the calcium levels are gradually increasing.
Yes, Swapnil, point well taken. What you said is absolutely correct. But here, again, when we see the literature,
the clinical improvement of the child tells you what you
see, this child was not asymptomatic.
You don't give steroid, you want to give steroid, somebody wants to give a loop diuretic, it's a clinician choice. And we try to minimize therapy till the minimum duration and the dose as much as possible.
You are increasing calcium excretion. That is going to
That's a logic. Logically, it's been whether it's actually documented. That's even I have not read it. Causing calciuresis by increasing nephroliters, I'm not sure about that.
Yeah. So
you have to see after 1 month or 2 months of.
So Swapnil, I take your point, and no doubt what you are saying is correct. But here, the important thing is we don't know whether calcium will rise from here. See, if I am keeping the child under observation, I don't know, tomorrow morning he might, we have managed this child in ward, okay, general ward, not in ICU. ICU has a continuous ECG, and there is ECG changes, then I'll do all these things. But here I don't know when the child got admitted, the next day the serum calcium might go beyond 2 millimole per liter. How would I predict that? Second thing, there are literature which have mentioned with asymptomatic with necrosis and nephrocalcinosis. There's a chronic calciuresis leading to nephrocalcinosis. So you can't prevent it. And we cannot put the blame on furosemide added only for a period of say 40-50 days leading to nephrocalcinosis. This child is not having nephrocalcinosis. And how much this nephrocalcinosis per se affect kidney function, that also is doubtful. So yes, we have to actually modify many things depending on what we are looking at now. See, literature might say many things. And it is most of the times it is biased kind of a thing, because how can you neutralize the under the drawer bias? I mean, if
Dr. Hari, I think we can do this discussion online also. Can do this. The discussion can go on and yeah. I think so.
So yes, what you said, point well taken, but then we have to actually modify, and steroids were started, of course, and it was a symptomatic child. So I thought initially adding furosemide would have been a good idea. And now the steroids are stopped, furosemide 0.8, and we'll be stopping it. So thank you.
Thank you, Dr. Hari and Dr. Sandeep. It was really a wonderful, interesting case, as we can see with a lot of discussions also. And I request our chairperson, Dr. Khobragade sir, and I request Dr. Devpujari sir also to join, Dr. Kiratkar sir and Dr. Khatwar to felicitate our today's wonderful speaker, Dr. Sandeep Yadav, who is a critical care consultant at New Healthcare City Hospital. And Dr. Hari Mangtani, we very well know him. He is a pediatric endocrinologist. So everyone please join in and do the honors.
Well done.
Thank you, everyone. And this is really a wonderful discussion. We are running little late. Everybody's interest is really maintained with this wonderful discussion. So moving ahead, I have Dr. Balwant Ramteke, who is a consultant critical care pediatrician at Neocare Hospital with Anil Jaiswal, sir. And they are going to present one more symptoms is intussusception, and along with NHL present intussusception.
खाली खाली येईल ना NHL. Next. Morning to everyone. Today I am presenting the case non-Hodgkin lymphoma presents as life-threatening emergency as intersusception in children. Sir, case presentation. This 8-year-old male patient presented with chief complaint of abdominal pain since 15 days off and on, lasted for 5 to 10 minutes, 5 to 6 episodes per day, now increases in intensity from 2 days. There is a history of vomiting 3 to 4 episodes per day since 3 days, and blood in stool since 15 days off and on, and decreased oral intake since 15 days. There is no history of fever, night sweats, weight loss, cough and breathing difficulties, altered sensorium or lower limb weakness. On examination, GC was poor, febrile, pulse was 129 per minute, respiratory rate was 39 per minute, weight is 25 kg, BP is 120/70 in right upper limb, pallor was present, and there was no significant lymphadenopathy on examination, no icterus. On systemic examination, per abdomen is soft, distended, there is a tenderness in periumbilical region, liver is palpable. Patient was investigated, so KFT is normal and serum electrolyte calcium was normal, coagulation profile was normal, and LFT LDH level are normal. So on X-ray chest is normal. On X-ray abdomen erect, there was suggestive of small bowel obstruction. USG abdomen we have done suggestive of ileocolic intersusception in right lumbar lesion, and we have done NCCT abdomen suggestive of ileocecal intersusception involving the causing partial obstruction and with few subcentimetric regional and mesenteric lymph node. that was the X-ray. So we hydrate the patient and manage with with antibiotic, and before operative procedure we have transfused the one PRC, and exploratory laparotomy was done for interception with resection of cecum with ascending colon approximately 20 centimeter with ilio ascending colon anastomosis, and that specimen was sent for histopathological examination, and after 7 days it turned out to be an atypical lymphoid proliferation favoring high grade NHL ileocecum with regional lymph node involvement. This is the picture of operative picture, and this specimen was sent. So it is the basically cancer of lymphoreticular system, and it is the third most common cancer among the children. It is most common cancer in adolescent group. That lymphoreticular system is consist of lymph vessels that are present in all tissue of the body. So lymphoma can present anywhere in the body, and it is lymph fluid that contain WBC, the mostly T and B cell, and lymph node, and fourth part is of lymphoreticular system is tonsil, thymus. So we are basically presenting NHL, so non-Hodgkin lymphoma. That pediatric NHL are aggressive and high grade at presentation. Survival rate for localized lesion is 90 to 100%, and generalized case 70 to 95%. And that NHL constitutes 60% of lymphoma in children. NHL has systemic disorder like severe combined immunodeficiency disease, Epstein-Barr virus, or Bloom syndrome. These are the major subtypes of pediatric non-Hodgkin lymphoma. First is lymphoblastic lymphoma, that is the cancer of precursor or immature T and B cell. Burkitt lymphoma, that is carcinoma of mature B cell. Diffuse large B cell lymphoma, that is cancer of mature B cell, and anaplastic large cell lymphoma, that is the cancer of mature T and B cell. So how it is presented, that clinical features depend on the site of involvement and pathological subtypes. The most of the 70% of the patient presented with advanced third and fourth stage with CNS and bone marrow involvement. B symptoms can be present, night sweats and weight loss of 10% in last 6 months. So there are nodal or extranodal. In nodal symptom, there is a painless, non-tender, rapidly progressive lymphadenopathy present, and site-specific symptom, that is cough, dyspnea, hypoxia in respiratory obstruction because of mediastinal mass. There may be dilated neck vein, facial swelling or discoloration in superior vena cava syndrome because of obstruction of superior vena cava in mediastinal lymph node. There may be ascites, present with ascites, increased abdominal girth in abdominal obstruction. Patient may be present with seizures, confusion, tonsillar enlargement or earache and hearing loss, pleural effusion and pericardial effusion. So they may presented with life-threatening emergencies. These are superior mediastinal syndrome, superior vena cava syndrome. There may be bowel obstruction, spinal cord tumor, DIC, and intersusception. This patient may be presented with tumor lysis syndrome, that is severe metabolic abnormality causing hyperuricemia, hyperphosphatemia, hyperkalemia, and hypocalcemia. So these are the staging of NHL that presented in 2019, that by International Pediatric Non-Hodgkin Lymphoma Staging. So our patient has primary GI tumor, usually ileocecal area, involvement of mesenteric lymph node, and that are completely resectable. So that comes under the stage 2. So how we diagnose the case? So we have evaluated with CBC, LFT, KFT, and electrolyte, LDH level, uric acid, calcium, phosphorus level. We have done chest X-ray, and in case of need a CT scan of neck, chest, abdomen, or pelvis. And diagnostic is excision biopsy on that, and bone marrow aspiration and biopsy to rule out the spread, and CSF cytology to rule out the spread. And most importantly is tissue tumor, that is we evaluated for immunophenotypic and cytogenetic, and it in that patient it turned out to be a Burkitt lymphoma. So what are the management of the, so we have to manage emergencies like tumor lysis syndrome, that is most common in Burkitt lymphoma and diffuse large B-cell lymphoma. So we have to hydrate the patient, give allopurinol or urate oxidase. We have to manage airway compression, and in some cases surgery is needed. And there is a chemotherapy regime, that is multi-agent systemic chemotherapy is available. There are multiple regimes. And radiotherapy is rarely required, maybe required in CNS involvement or in emergency for superior mediastinal syndrome or spinal cord compression. And surgery for low grade and the tumor, if the tumor is resectable. So these are the drugs available to treat, that is corticosteroid, vincristine, L-aspergillase, anthracyclines, cyclophosphamide, methotrexate, etoposide, doxorubicin, and cytosine, arabinocyte, dacarbazine, and bleomycin, and procarbazine. So there are major subtypes. So we that is lymphoblastic lymphoma. It is a neoplasm of precursor or immature B cell or T cell. It mostly manifests as intrathoracic or mediastinal supradiaphragmatic mass, and CNS and bone marrow involvement is very common. And in lymphoblastic lymphoma, there are less than 25% of lymphoblast with extramedullary involvement. For localized stage and advanced stage, BFM 95 protocol for 12 to 24 months. Chemotherapy is needed, sometimes cranial eradication and intrathecal methotrexate are required. And there is a newer drug is coming, that is nelarabine, can be used. Then Burkitt lymphoma, it is the neoplasm of mature B and T cell, and is the most common subtype of NHL in pediatric, and it can mutate to CNS and bone marrow. There are 3 subtypes. The endemic Burkitt lymphoma, they are mostly presenting as head and neck tumor, especially jaw, and sporadic Burkitt lymphoma can present with abdominal tumor with ascites and distension, can be present with intussusception. And third subtype is immunodeficiency Burkitt lymphoma. For localized stage and completely resectable lesion, there is a FAB and LMB96 protocol or 2 cycle of COPAD for 6 weeks to 6 months. In our case, a patient has already received 2 cycles of chemotherapy and has responded to the treatment. In advanced cases, FAB and LMB96 protocol, that is involving multi-agent drugs, or NHL BFM 95 protocol is available for 3 to 5 months. There is monoclonal antibody, rituximab trial can be given. Then third subtype is diffuse large cell B cell lymphoma, that is presented primarily as abdominal or mediastinal and can manifest to the bone marrow and CNS. There are 3 subtypes: the germinal center B-like, that is pediatric cases, and it has good prognosis. Second is activated B cell, and third is primary mediastinal B cell subtype. It has worse prognosis. For stage and completely resectable lesion, FAB LMB96 protocol trial or 2 cycle of COPAD for 6 weeks to 6 months. And for advanced cases, FAB LMB96 protocol or NHL BFM 95 protocol for 3 to 5 months. The fourth is anaplastic large cell lymphoma, that is presented primary cutaneous subacute nodule or sarcoma or tumor, or with systemic with dissemination to the liver, spleen, lung, and mediastinum. And in this case, the bone marrow and CNS manifestation are rare. The anaplastic large cell lymphoma, they are 70% T cell origin, 20% null cell origin, and 10% B cell origin. If for localized stage, resection is sufficient, and for advanced stage, multi-agent chemotherapy is required. And for relapse cases, brentuximab and crizotinib trial is available. So in that case, what are the take-home messages? The interception after the age of 3 years, pathologic lead point should be sought. And any patient with persistent or unexplained lymphadenopathy, unassociated with any other underlying inflammation or infective process, should be ruled out for NHL or lymphoma. Thank you.
For your excellent presentation. We have at least not seen present. I just want to know only 1 or 2 points whether this involves more of a small intestine or a large intestine as a lead point for the interception.
Ileocecal.
Ileocecal. So it was more of a ileum.
Yes, sir.
Which was interception. Now, in this case particularly, can we go for a conservative management because patient is say high risk patient, lymphoma, he has got suppose opinions, other hematological complications. Can we go for a say conservative management versus operative management?
Sir, interception, so we have to operate, sir, because that is life-threatening emergency.
Barring suppose the lymphoma, suppose in known patient of just plain simple interception is there.
Because sir,
nowadays they should go for a hydrostatic.
Because sir, on admission, sir, we have not diagnosed that. We are diagnosed after 7 days. That histopathological report came, and until then we have managed and we have planned discharge on day 7.
Most of the times, determine that whenever there is a lead point, it is always better to operate there rather than
Yes.
because the
Yes, sir.
chances of recurrence is very high in such cases, and therefore these are the patients which needs to be operated. Any other special message which you want to deliver in this particular case? How was the follow-up in this patient?
So now his patient is followed with NCI, sir. He has completed cycle there. He has not followed at our side.
I would like to add, Dr. Nitin from NCI, which I was referred to us after the surgery and surgical diagnosis. So as you rightly said, if there is a lead point, especially child is more than 3 years old, we should look for a lead point. And in those cases, there is it's not advisable to wait because you get some pathology leading to interception. So these either a McDonald's or a lymphoma, so these children need to be operated.
Yes.
And only a surgical diagnosis as neocat was operated and after surgical diagnosis, child was referred to us. Interception is in even in literature, it's a rare presentation of Burkitt's, but in the last 2.5 years, we have seen 5 children who were operated for interception and then turned out to be lymphoma and referred to us. So we have seen 5 cases out of over 15 Burkitt's lymphoma, 5 were presented to us with interception. Ours is an exclusive oncology center, so we get children who are already operated, diagnosed and referred to us. So one message we will like to give is if such thing is suspected, lead point is there, till the histopathological diagnosis is confirmed, it's important to monitor them for tumor lysis syndrome, hydrate them well, and try to get the histopathological report as early as possible because Burkitt's is a very rapidly multiplying tumor. So if you make the histopathological diagnosis, you can start them on a pre-phase chemotherapy, which is considered as 3 drugs, dexamethasone, vincristine, and cyclophosphamide. And once the child recovers from the surgery, then 2 weeks later, the definitive chemotherapy can be started. So monitoring of TLS parameters, tumor lysis syndrome, and hydration is important.
It's a very transparent case. Few important things as far as the practical. Whenever we see a case of interception, basically interception in this case, and then coming to the. So, if it is idiopathic interception, usually there is no cause, usually it happens below the age of 2 years. So, whenever you see a child presenting with interception, below 3 years, some says 3 years, think that it's not because of the lead point. Okay. And if you see a child clinically interception. X-ray, there is no X-ray, abdomen X-ray, there is no crescent sign. In interception, you get a crescent sign said to be pathognomic in nearly 60% of the cases. But in that, nowadays there is no crescent sign. They say to diagnose interception, usually 80% you can diagnose with the help of USG, where you can have a target sign or a correct sign. That is, you need not go for the, or we never go for the CT for diagnosing interception. That is one. When you are thinking a interception after the age of 3 years, always think of the pathological lead points. And in frequency, in order of frequency about the lead points. Number one is a Meckel's diverticular. But how to think it's not Meckel? Because in Meckel's diverticular, you get a recurrent history, and you get a recurrent blood in the stool. Here in this case, since 15 days. And usually, Meckel's diverticulum presents below the age of 2 years. So clinically, this lead point is ruled out. Number two, you can have a interception duplication, where it can be lead point for the interception. That is not there. Third is a polyp. Usually in polyp also you get blood in the stool and present like this. But in that case, interception is a colonic variety. It's not the illegal. And what they say in most of the book, they say the dictum. Whenever you see a child with interception after the age of 3 years, lymphoma should be sought. Lymphoma should be thought first until proved otherwise. So clinically, interception more than 3 years of age, that 8 years child presenting the lymphoma is on your back. First differential diagnosis. First, rather than there are other conditions also like hemangioma and all those things, but they are the 4 important things. Then clinically, can you justify to say it's a Burkitt lymphoma? Yes. Clinically. Looking at this pathological report is there, because there are no lymphoblasts in your this, and there is no significant lymphadenopathy which you get in the you can get in the lymphoblastic variety. Another is anaplastic. Again, anaplastic also present with the lymphadenopathy. There is no significant lymphadenopathy. And what remains is Burkitt lymphoma. WHO says a endemic, mostly seen in the African countries. Usually, Jai is called. Most common presentation of the Burkitt lymphoma is interception. So whenever you think of interception after the age of 3 years, think of the Burkitt lymphoma, which is said to be the sporadic. And the Burkitt lymphoma can be associated with the immunodeficiency syndromes, like this. So clinically, it's a very good case to analyze and spit out. So. It's a very good take-home message which you have given. Just this is for this case. But whenever you think of the lead points, think of the descending order of the pathological conditions.
Thank you, Dr. Ramteke. It was a wonderful case. And I request our chairpersons to felicitate Dr. Ramteke, and I request Dr. Nitin from NCI to join. Please. I also recognize the presence of our ex-executive CI member, Rao, and I recognize the presence of Dr. Pazare sir.
Good case.
Our academic feast and clinical meetings are always great with the presence of our chairpersons, Dr. Raut sir and Dr. Khobragade sir. And it cannot end without felicitating them. So I request Dr. Kiratkar sir to felicitate them. And Dr. Too many felicitations. I request Dr. Anil Rao, Dr. Pakmore to join in.
एक मिनट फोन करता हूँ.
Thank you all. And I request now Dr. Khatwal to give the formal vote of thanks.
So not wasting much of time. On behalf of AOP Nagpur 2022, I would like to thank our speakers, today's speaker, the eminent speaker, Dr. Dev Pujari sir, who is always there for us and always update us with the newer insight in the pediatric. And today also he has given us the newer updates regarding the clubbing. Thank you so much, sir. And our the speakers, Dr. Sandeep Yadav sir, Hari Bantani sir, Nisha Ramteke ma'am, Dr. Vasant Davas, Dr. Balwant Ramteke sir. Thank you for wonderful case presentation. Thank you so much. And I would like to thank our chairperson, Dr. D.S. Raut sir, Dr. B.P. Khobragade sir, for their keen observation and giving their valuable inputs in each and every cases. Thank you so much, sir. I would like to thank our President Kiratkar sir, Senior Dr. Thote sir, Pakmode sir, Raut sir, for their today's presence. Thank you so much. And I would like to thank our moderator, Archana Jaiswal ma'am, for smoothly conducting today's workshop. Today's clinical meeting. And last but not the least, our enthusiastic audience, offline as well as online, for their presence and enthusiastically participating in today's clinical meet. Though there was a technical problem, we will try to sort out this next time. And thank you so much for this, for their presence. With this, I would like to end today's clinical meet. Followed this, we will have a brunch. And there is a EB meeting also. I would like to invite each and everyone to please come for the today's meet. It is